Thank you. What I'm going to talk about is IFIS and the BX. These are two topics. So I have a financial disclosure to make in terms of my interest in the BX Pupil Expander and ownership in MedInvent Devices Private Limited. So I'm thankful to the ophthalmic fraternity for all the honor bestowed upon me. So now let's see this particular case. A standard cataract surgery was scheduled for toric IOL. Yes, a little bit of short eye, 25-day with 4.5D cylinder. I guess not many of you would choose to do iris hooks or a pupil expander over here. So same with me, but as I was injecting viscoelastic and coming out, I noticed that that iris, there was a little slight bit of hint of iris prolapse over there. So I thought I'd rather be safe than sorry, so went ahead and used a HEX pupil expander. But then, and I thought things would be fine because now I had the pupil under my control, but then to my surprise, I see the iris prolapsing through the side port, and well, as we progressed a little bit more, we had the iris prolapsing through the main incision. But the good news was my pupil was constant size, and I could go about doing my phaco surgery peacefully. We did manage to tame that iris prolapse and bring it back and do that surgery, put in that IOL, and we got that fine. We did that all well. But yes, had I not used a pupil expander that day, I would have been in big trouble. So, ex post facto, how many of you would have used iris hooks and pupil expanders is a question, which maybe you would now have second thoughts. And what we need to remember is iris hooks and pupil expanders have a definite role in IFIS. They do not prevent iris prolapse. What they do is give you a constant pupil size, which adds to the safety and for visibility. If you thought that Indian eyes are kind of immune to IFIS, well, we are wrong. This is a wonderful paper, and this suggested that the incidence of IFIS was much higher in India compared to the other literature available, and current tamsulosin, alfuzosin use, and hypertension are important risk factors. This has been, again, further stated in other publications. So that is the list of causative factors for IFIS, and if you can see, no amount of history taking is going to be foolproof. So given that list, every alternate patient is a potential candidate for IFIS, so we need to brace ourselves in the theater for surprises. Safe pre-op pupil size is something which we talk about often, and we make a note in our pre-op examination as, okay, 5 millimeters pupil, or 4 millimeters, 6 millimeters, 8 millimeters, and we would think, okay, this is not a potential candidate for IFIS. Well, that also has been kind of proven a little wrong by this paper by Alessandro Casiccio and co-workers in 2011. For a pupil 7 millimeter or smaller, the risk of IFIS existed regardless of alpha-1 blocker intake. So that is huge. So the lessons that we learned, that IFIS can occur in pretty good 7 millimeters pupils also, and we need to remember that women are often on tamsulosin for UTI and various other reasons. And like I said, iris hooks do not eliminate iris prolapse. What they do is give you a constant pupil size for good visualization and adds to your safety. So this is what we need to understand, is that there are basically two subsets. One is the rigid pupil, which is basically a fibrous band or a non-elastic pupil, and the elastic pupil, which is going to stretch and come back. So if we look, these are a few videos, very old videos, even before IFIS was recognized. I just pulled them out from my archives, and if you see that, that is the fluttering of the iris. That's just grade 1 IFIS, which is rather the benign types. And this is a myopic eye where we are dealing with IFIS, and look at what is happening. The pupil is large to start with, comes down on me, iris starts prolapsing, I re-inject viscoelastic and inflate the antechamber, and the pupil goes back to its big size, and yet again it can come back on me, and it's a cat and mouse game which goes on one after the other. So try as much as I may, this is going to keep happening because that's the nature of that iris. So now, if we thought that iris hooks are going to add safety and not going to cause iris prolapse, again we are wrong. So this is a case where I used iris hooks, and even before I had finished my capsulorhexis, my iris was frayed and looked like a fishing net, and I had difficulty putting my phaco probe in. So that is how IFIS can behave. It's a huge spectrum. So and then of course you will have that patulous iris over there. You can see that the patulous iris is like a sail over there, and you need to be careful about putting and that's that knuckle of iris which is there. We don't need to deal with it. And every time you go into the antechamber, whether it's a phaco probe or your IOL cartridge, you need to be careful that we don't engage that prolapsing iris and cause iridiolysis. So, this is, in summary, the take-home messages for IFIS. We have already dealt with all of these. The important thing is that stopping tamsulosin is of no value whatsoever, and you may actually land up with urinary retention, and it's not going to serve any useful purpose for us. And tamsulosin intake, even 3 to 7 days prior to your surgery, can really cause IFIS. So these are the complications. And is that my time or? Okay. So mechanical dilatation is, you can use pupil stretching, but you need to be very careful where you use it. And IFIS is going to be useless, so we have the iris hooks and the pupil expanders, the mulligan ring, the BHEX pupil expander, and a whole lot of them. So that's the BHEX pupil expander. We have a hexagon with notches and flanges. The alternate flanges are tucked under the pupil margin, so the notches engage the pupil margin and cause pupil expansion. The mulligan ring is brilliant, no doubt about that, and Boris deserves all the credit for bringing a wonderful tool to us. But then my problem was it's a biplanar device, and it snags the incision on the way in and way out. And that's exactly why they need an injector. All devices are biplanar devices, and that's why they require an injector. So I had to think about something around this problem. So I had an inventive concept, and that's a patented device now. So we thought that the iris could be bent harmlessly and reversibly. So we brought the device to a single plane, and the iris was now being bent at the notches, and the device remained in a single plane. That way it wouldn't snag the incision on the way in or way out. And we did not require an injector. We could use a 23 gauge forceps to take it in and bring it out, and it just glides through the incision. My suggestion would be that you should watch a few videos, because the design looks very simple, and it could be actually deceptive. The small tips, you need to keep the antechamber underfilled. Overfilling pushes the iris against the lens capsule and would make it difficult for any device to be used. So when you inject viscoelastic, the iris gets plastered onto the lens capsule, so you need to inject viscoelastic under the pupil margin to lift off the iris a little bit, and that's how you make space. So that's the injection of viscoelastic. Very little inject viscoelastic in front of the pupil. What you need to do is a little bit of inject viscoelastic under the pupil margin, so that you have a space for the device. So, but if your pupil is less than 4 millimeters, and especially if it's a rigid pupil, you need to stretch it a little bit bimanually to use a device, because that way you get a cosmetically good pupil, and you have a controlled sphincter tear, which you'll have to do anyway in a rigid pupil. So how do you differentiate a rigid pupil from so inject BSS from the side port, and if that pupil expands slightly momentarily, you know that it's an elastic pupil. You see what's happening over here. Inject and it expands. This is going to be good. But look at this. This is pseudoexfoliation pupil, and you're going to inject viscoelastic, and it's not going to budge. So that tells you that it's a rigid pupil, and you will need to, and this of course is absolutely rigid pupil. It's a little bit of ectropy and UV over there. So you will need to do a bimanual stretch and then inject a viscoelastic and get that pupil to a larger size. So that's something we've talked about. So rigid pupils, 4 to 5 millimeters, controlled sphincter tear. A bulky pupil expander may stretch the pupil but would produce uncontrolled tears and would be unwieldy. And a delicate device like the BHEX would not do that, but you need to stretch the pupil in advance to get a cosmetically good pupil. Let's see what we did over here. This is a uveitic pupil, and I tried doing a synechulisis and release that thing, and then I did membrane. I tried to remove that, I tried to remove the membranes with the forceps, but really didn't help. And so we went ahead and did a stretch. And if you see, I'm not doing a limbus to limbus stretch. I'm not doing it angle to angle stretch. It's just a limited stretch so that I get a 4.5 to 5 pupil, which allows me to put the BHEX in. And then we went ahead and we put the BHEX pupil expander in, and we had a nice round hexagonal pupil, which allowed us surgery and good visualization. We now recommend only the 23 gauge BHEX forceps, because it gives us the most controlled, So that's how we take the BHEX inside and tuck it under we need to place the device onto the iris first. We do not want to tuck the first flange in the first pass. We need to place the device onto the iris, and then we go ahead and tuck those flanges, because then we get the entire device in one plane and onto the iris. Fixation of the globe helps as you're manipulating with the 23 gauge forceps. What's important is, Kumar showed you a lot of videos on with the Mulligan ring after a capsulorhexis has been done. Well, it's a little difficult with the Mulligan ring because your gap with the Mulligan ring is something which you can't see. It's away from it, and you really can engage the capsulorhexis margin, and it's potentially dangerous over there. So here with the BHEX, you can just inject a little bit of viscoelastic on the anterior capsular rim and just lift off the iris. And since you can see the notches, they're staring at you, you practically have no chance of engaging the capsulorhexis margin. And as you advance that flange, you have instant confirmation that you have not engaged the capsulorhexis margin. And under direct visibility, you're tucking those flanges. So it's a very safe device. And you really don't need so many manipulations. So once you have done that, you have a nice size and a pupil, and you're back to your comfort zone. So one more small tip is that the trailing haptic, since the BHEX expanded pupil is 5.5 millimeters, it is desirable that you put the trailing haptic in one single motion into the bag. If you fail to do that, well, there is a remedy for that. I'll just show you. Now, this is how we put the trailing haptic in one single motion into the bag. That way, you do not have to push the ring and the pupil margin. Otherwise, you'll end up dislodging the pupil margin, the ring from the pupil margin. If you cannot do that, what you need to do is push the trailing haptic optic junction in a way that the leading haptic optic junction kind of flexes, and the push is over there. You do not push the ring or the pupil margin. And then you tuck that trailing haptic into the bag. Removal. So, and the BHEX removal is very simple. You can just hold a flange, disengage 2 notches on either side, no heroics, no rocket science, and just draw it out of the incision, and the trailing notches just disengage spontaneously. You could even remove it through a 1 millimeter side port, and you just inject viscoelastic under that flange, hold that with a forceps, and let me just advance this a little bit. And you disengage that notch over there, the 2 notches on either side, and you just draw the device. Don't bother with the trailing notches because they're going to disengage spontaneously. That's how the mechanics of the device works, and you have a wonderful, nice pupil. These are a couple of publications in the Indian Journal of Ophthalmology and the JCRS. You could read them. Thank you very much for your attention. Sorry I overdid my time.